This is my name, and I'm working in Riyadh, King Khalid Eye Specialist Hospital. I'm chairman of the anesthesia department there, and I welcome you all. I was expecting more people because anesthesia usually in the ophthalmology conference is a very rare thing. I thought probably, you know.
I was surprised when I saw the
Yeah. Yes, because everyone they focus on ophthalmology, techniques, but anesthesia, I think it is one of the important part because the ophthalmologists they cannot work without us. So
anything happened to the patient, they will accuse us.
yeah. Okay, well, so, but anyway, I hope instead of making it as a lecture, I prefer just to make it more interactive so that we can just discuss and share our experience and ideas. And knowledge is, nobody is right and nobody is wrong. Everyone have their own reasons, and some people practice is different than the others, but everyone have a reason. Before we start to talk about the ophthalmic anesthesia, this is just the latest. This is, you see here, this is 2017 statistics of the anesthesia that we did in King Khalid Eye Specialist Hospital. This is month-wise, but just look here at the results. We did the total cases under local anesthesia is 5,000, this is like 50%, okay, and the general is around 40%, topical close to 10%. If you consider this and this together, so it will make 60%. And this is the total for 2017. We operated 11,216. So this, the reason of putting this slide is just to give you an idea that ophthalmic regional anesthesia is, did you do something or it's me? Yeah. This is and any patient in our hospital should be given a local anesthesia unless there is a problem or some sort of contraindication. General anesthesia is not a first choice for any case. And although we have some surgeons who prefer general anesthesia. Pediatric, you have no choice. So pediatric is, but I mean adults. For the adults, we don't give general anesthesia to any patient unless the surgeon convinces that he has a particular reason and that reason is valid. So we will talk next, but the question is like, I'm saying why local anesthesia? And these are the most important things that why local anesthesia. It is suitable for all adult sick patients. In ophthalmology, you know, we have to remember that we are dealing with extreme of age. Either our patients are too old or they are too young, born with congenital problems, glaucoma, retinoblastoma, strabismus, many. So either we're doing cases in Riyadh 5 days old, beginning with 5 days old, with congenital problem. Local anesthesia gives you less physiological disturbance. Means your systemic system of the body, homeostasis of the body is least disturbed, and provide you excellent anesthesia. It provides you better anesthesia, analgesia than the general anesthesia, because general anesthesia, what we give to control the pain. Anesthesia is not only to put someone unconscious, also to control the pain. We use narcotics. Those narcotics have its own disadvantages. But still, none of the systemic narcotic is able to give you analgesia which is equal to the level of local. Local means you completely cut off the nerves. So it's nothing. Narcotic, you have to go dose. If you increase the dose too much, you have disadvantages. If you give too little, patients still feel pain. So that is why local, this is the best choice, and it affects the intraocular pressure very little. And this is one of the important complications that you can prevent, that is the postoperative nausea and vomiting, which is associated with the general anesthesia, and particularly in children, as strabismus is the known surgery that causes the most nausea and vomiting, and young age group, the experience is more. Then, easy, and it reduces the hospital stay. So the patient come in the morning, most of the cases they can go home in the afternoon, excluding retina. And then the cost, that what we calculated, it costs less than 20 real per case. It does not include the fee of the anesthetist and electricity and water, but I'm just talking about the drugs and the monitoring things that you use. It costs less than 20 real. But in comparison, a usual average general anesthetic cost is between 500 to 600 in our hospital. Maybe other places it's different. Certainly, it has some disadvantages because we are always afraid about the complications of local anesthesia, and we will discuss the complication in detail later. And then again, skill. It's a highly specialized technique. It's a blind procedure. That is why you need to be skillful before, because eye, it's damage to the eye can be devastating. And some patients it is not very suitable. We will see which patient it is not suitable. In between, if any of you want to share any idea or ask any question or any discussion, we can do it. I mean, let's consider not a lecture. Okay, but before the block, we need to have sound knowledge of orbital anatomy. Again, it is what we talk skill. So you need to have ophthalmic physiology, pharmacology of local pharmacology of local anesthetic drugs, ophthalmic drugs as well. For example, we are using the temolol and some steroids and different kinds of ophthalmic drugs that we have to be aware of. It has interaction with the anesthetics. And then the general preoperative assessment of the patient. If the patient is hypertensive, diabetic, asthmatic, the patient have thyroid problem. So that need to be assessed. So we assess every patient, general, and the next slide you will see the local, the eye examination as well. And we have to communicate very well to the patient so the patient is completely in the picture. Now, in the general preoperative evaluation, all the patients that we deal with the very elderly patients, old patients. Most of them have hypertension, ischemic heart disease, sorry, it's written twice, congestive heart failure. Even we give anesthesia to congestive heart failure patients. Asthma, COPD, thyroid. So for all these patients, local anesthesia is the best choice. For certain cases, we have to avoid it. For example, if patient language, a patient is speaking a language and you speak something different and you cannot communicate. So the cooperation, in that case, it will be difficult. You have to put him to sleep. Then that's the better, if there is no contraindication. Some patients will come with schizophrenia, dementia, movement disorder, tremors. Those are, you have to see the risk and benefits. Those are not very classically fit patients for local anesthesia. They are candidate for general anesthesia. This is, I think most of you are ophthalmologists. This is one of the important things which we face in our everyday practice. That's uncontrolled coughing. If a patient have any recent respiratory infection or whatever reason, but the patient is coughing, it is extreme discomfort for the patient, for the surgeon, and sometimes it can be even risky if the eye is open. Surgeon is performing a PKP and the patient cough. He removed the cornea and the patient is coughing. So in that situation, we have to, this is not a patient for local anesthesia. This patient need a general anesthesia. And then some patient, like very obese patient or patient with congestive heart failure, you put them on the table and they say, I cannot breathe. You have to keep the table like this. So those patients, that is a big dilemma. They are not fit for general anesthesia and they are not fit for local anesthesia. A patient with congestive heart failure, general anesthesia is equally dangerous. So then you have to weigh the risk and benefits. And if the operative time is very long, sometimes, doctor, you are a retina, some retina cases go 3-4 hours. The patient get tired on the table, and then he start moving around, he become discomfort, and then many times it happens that you have to convert him to a GA. It's better to think in advance rather than deciding later on the table. And some patient may not give you a consent for local anesthesia. Now, what about the eye local examination? These are not the age group that we give a local anesthesia. We give to some children, we give local anesthesia, not to all, but in general, we are talking about adults. Any visible abnormality from outside the eye, if you see. Especially, sometimes you will see the eye, patient come for a block and you see this, it looks to you that it's like infected. You call the surgeon, discuss with him, do you want to? Surgeon will tell you, no, I saw yesterday, patient was okay. He developed infection probably overnight, or we will cancel this case. So local examination of the eye is important. And then the globe evaluation, the probable depth. Remember one thing, what I've seen in my experience of 14 years in ophthalmic anesthesia, every eye is different. No two eyes are similar. There are differences with the shape of the face, racial differences. People with flat face, their orbit is different. Then the projection of the eye is different. If the eye is proptosis, I'm not talking about pathological, but I'm talking about even naturally. Some people eyes, they are more projected outside, some are deep. Now the deep eye, the equator goes deeper. In the projected eye, proptotic eye, sometimes you just pull the eyelid down and you can see the equator. So every eye is different. That is why we need to evaluate every eye separately. And this is, if we are blocking an eye, we need to know the history of that patient. Because sometimes you may not know that a patient had previous surgery. A patient coming with scleral buckle and you are trying to give him subtenon. You will damage the eye because the needle will not go. Because the eye is circled. So visual acuity of both eyes is important, especially if you are blocking a patient, let's say on an anticoagulant, a high-risk patient. You need to know what is the visual acuity of the other eye. If the other eye is also, the vision is very poor, maybe you can change your plan. Because what if you damage this eye and the patient cannot see from the other eye as well? He can become completely blind. So these are the things that we need in the preoperative assessment to think. And we do, we do the B scan for all cases. Occasionally some patient will come without scan, but we do it for all patients. Okay, but in case if you don't have it, then any myopic patient, consider him a patient with a long axial length, because you need to know the axial length before you block. You need to have an idea. Okay, let's go to the, now this is one of the thing that worldwide is a discussion, what to do with a patient on anticoagulants. No place has any 100% fault proof system. Every place have its own, but these are just, this is the British Ophthalmic Anesthesia Society recommendations. Again, it is not a standard. Many people, they practice different from it, but this is just for a reference. If a patient is on anticoagulant or antiplatelet drug, what we do? Like patient on prosthetic heart valve, you cannot stop his warfarin or any other anticoagulant. So they recommend to continue it and just calculate the risk and benefits, and you have to be in close contact with the cardiologist. In KKH, our hospital, we accept INR 2.5. We block a patient if the INR is up to 2.5. If it is more than 2.5, then we reduce the dose and then we wait 1 day or 2 days, and once it comes in the range, then we block. But all patients up to this level, we block them. And then aspirin is now out, nobody stop it worldwide, so we also continue the patient on aspirin. The same is Plavix. We don't stop it. Occasionally, we may adjust the dose. And this is a new drug, rivaroxaban. How many people are familiar with this name? This is a drug which was introduced in 2007. Rivaroxaban, it's a factor 11 inhibitor, a thrombin inhibitor, and this is a drug, and then there is another drug in the next slide. Let's go to the next slide. This one, dabigatran. This is also a direct thrombin inhibitor, and these are the drugs that they are very little studied. So there is no full data. Even you cannot measure the degree of anticoagulation because there is no test for it. For example, for the warfarin, we check the INR. Here there is no INR, will not show you anything. PTA, PTT will not show you anything. So it is difficult to measure, and nowadays, because this is a newer with a drug with a little side effects, so the physicians are prescribing it more and more. You will see in your practice patient coming, and they are on dabigatran or rivaroxaban. So there is no even therapeutic range. You don't know what range it is more effective. So this is a drug which is still under study, but in Saudi Arabia it is available, and we see patients who are on this drug. So, and then there is no antidote for it. You cannot reverse it. So if a patient is on dabigatran, you have to wait for him. But the recommended time for this drug is 2 to 5 days. But for the rivaroxaban, if you wait for 24 hours, the next day you can block a patient. But again, you don't have any lab test to tell you that now the level is down or up. All we go by the half-life of this drug. For rivaroxaban, the half-life is about 12 hours, and the next 12 hours it declines, so we consider it like, okay, you can block this patient after 24 hours. Okay, and now these are the type of the ophthalmic blocks that we do, and all of you are familiar. I will not go in detail, but topical, peribulbar, retrobulbar, subtenon, intracameral, subconjunctival, local anesthesia for DCR procedure, and we use combination of these. For example, we combine topical with intracameral. We combine intracameral, but before that we give we give a topical, and then we give subconjunctival injection. We use the insulin needle, which is 32 gauge, and just raise the conjunctiva and inject, like you giving injection at the end of your surgery, a steroid, and it's the same. Give here and there. It will give you excellent anesthesia, which is enough for superficial procedures like cataract, or even some people, some private places, even they do the PKP with it because they don't have a facility for more advanced anesthesia. So we do combination as well. Now this is, most of you are, I suppose, are ophthalmologists, so I don't go in detail. You know this part better than me, but this is the anatomy, and you see here this is the rim of the orbit, and that is 3 main bones which is making. But the important thing is these fissures, superior and then the optic canal. And one more thing which is important is the where it is written. Ethmoidal ethmoidal bone and the ethmoidal sinus, which is nasally. And so that is important to know from the anesthesia local medial block point of view. Again, it is the same, but here what important to know is that the globe is not central. The globe is closer to the superior rim than the inferior. So here, on average, the distance between the globe and the superior orbital rim is about 4 millimeter. The medial, it is about 5 to 6, and the lateral is about 4 to 5, but this is the place which is up to 7 millimeter. Average distance from the rim is about 7 millimeter. So that is why it gives you wider entry point, and medial also give you a wider, but superior, it is a very narrow, and if you don't use the correct angle, there is a possibility you can hit the globe. Here, just to show you the muscle cone and how it arises, and here how the optic nerve enters from the optic canal. And the important thing to see is that, you see, if you, the eye is like a cone. So the base of the cone is to the front, and let's say it's like this, so the apex goes to the behind. So the more you go deep, the more crowded the structures and the tissues are. The more you are superficial, the more is the distance between the different, for example, mainly like the muscles. Okay, in here we can divide the eye. There are two types of theoretical division that we have to keep in mind before we block. One division is this. Here, intraconal and extraconal. So this is the cone. This and this is the cone. The space inside this cone is intraconal, and around this is extraconal. These muscles are, although they are separate, but there are fascias which are connecting these muscles to each other, which are not very organized. It is not like a completely sealed membrane, but there are fascias. If you go in the detailed anatomy, you will see that there are. So if you deliver anesthetic inside this cone, that is the best and the most effective. But what we do, because of the risk involved, we perform peribulbar. We inject it somewhere here, and we assume that it will diffuse into the posterior structures. Sometimes it diffuses good, sometimes it doesn't diffuse good. It's a blind procedure, so if your block is not effective, I don't blame anybody. Give a supplement, or nobody can see it. Neither the surgeon can see it, and nor the anesthetist can see it. All you do is just based on your practice and your skills and your... Okay. So the intraconal area is, you have all these structures which are important to block, to have a good block. And this thing, we will see it in the next slide as well, but this is one of the important, small point, but very important. The dura is adherent to the optic canal and the optic nerve itself. So the dura from the brain is coming out with the optic nerve. It accompanies the optic nerve to some distance. So we have to keep away. Although it is very deep, with the routine size of needles, you will not reach there unless you are using too long needle. If you are using a needle longer than 32 millimeter, then yes. But if you are using shorter needle, you will be away from it. Now, this is the same thing that we talk. But in case, this is the optic nerve. In case if you put an subarachnoid injection here, so this is the pathway of the anesthetic to go to the brain and spread. And here you can see cranial nerves, pons, and midbrain. And imagine if you block midbrain with a good amount of anesthetic, because here you will inject directly into the CSF or along the course of the optic nerve. If you block the center of the brain, you block everything. You block the whole body. So the patient will lose consciousness immediately. You have to resuscitate that patient. In general, it takes about 2 to 10 minutes, and it also depends on the dose. How much you injected, that is more important. If you inject it, because we have seen patients. This is not the only way to, by the way, for the anesthetic to penetrate into the brain. There is some local diffusion as well. Even you don't inject in the optic canal, still some anesthetic can go through the fissures and through the optic canal into the brain, and it will cause, but that effect will be localized. But we have seen patient with mild transient impairment of his brain function and get confused for some time, and then after 10-15 minutes the patient, we see he become okay. So not necessarily injection here, but injection here is devastating. That is a disaster. Okay, here I will not go in the detail because all of you know the anatomy better than me, but just to tell you, this is the most important nerve which is supplying fore muscle. And the important thing is to look here in the center, that is the ciliary ganglion. Here, this is trigeminal nerve, and the nerve is cut. So you can't see it here. You can see the trigeminal in this picture. And the superior branch of the trigeminal, this is the Gazarian ganglion, where it divides in 3 parts. And this is the superior part which give nerve supply to the interior parts of the eye, iris and subconjunctival. And so that is not shown here, but we have to block this and we have to block this branch. This supply of the ophthalmic branch of the trigeminal nerve explain when you give a block, and you see some patient complain you, this, if you block left eye and he say, oh, I don't feel anything here. Sometimes the patient scratch here, sometimes scratch in the nose here. And some patient will tell you the upper dental arch on the similar side, he say, oh, I have a tooth anesthesia, I cannot feel in my teeth. So this is mainly of the blockage of this branch of the trigeminal nerve, because you put anesthetic in the eye, and if it, even this, there one tiny inferior nerve also coming from the same branch. Sometimes it will give you little anesthesia here to the cheek and this part. Don't be afraid. That is normal. And in fact, it is a sign of a good block. But of course, it should not be more. Okay, here it's just the venous network behind the globe. This is the arterial and this is the nerve, but it's okay. It's more or less the same thing that we studied in this thing, that the important thing is to send as much as anesthetic solution to this intracorneal area, because this is the place which sends everything into the eye, either muscles or nerves. Okay, now this is a question, and the last few years there is too many articles published about the length of the needle, and short needle or long needle. This is a dilemma. Anybody can share any opinion or any idea about what is the size of needle that you are using in your practice? The needles available in our hospital are 15 millimeter. We have 12 millimeter long, 15 millimeter long, 25 millimeter long, 32 millimeter long, and 36 millimeter long. So we have all these needles available, but the most common we use for inferior lateral is 25 millimeter. And the most common we use for the superior nasal or medial is 12 millimeter. So we don't go deeper than that for the peribulbar block. If it is a retrobulbar, then we use the long needle, and the gauge of the needle is, all of the needles are 25 millimeter of gauge. Some needles now, the newer are 28. Okay, so this is just to give you an idea. This is the MRI, coronal plane of the eye. Here you can see these two pictures are taken for the same eye at two different depths. This is 12.5 millimeter deep, and this is 25 millimeter deep. And this is just to give you idea. At this depth, you see these are the muscles here, and you can see, let's say it in this structure, this is then hand drawn. So the crowding is very little, and the distance between the different structures and nerves and muscles is more. The distance is more, and the belly or the size of the muscles is small. But if you go at the depth of 25, it changed to this way, and that means the deeper you go, the more risk you are taking. The chances to hit a structure increase directly if you go deeper and deeper. Again, it's the same thing, but you can see here that based on that MRI, this is the area. This is the area, infero-nasal corner and superior-nasal quadrant, which is relatively empty. We use superior-nasal supplement sometime, but this is a crowded area. And you can see there is a nasociliary nerve, and there is a superior oblique muscle, superior ophthalmic vein also coming here if you are going deep. So if you are choosing this area, please do not use a needle longer than 12 millimeter. Because if you go deeper, even you can hit the trochlear pulley of the superior oblique muscle. But this is the area which is just between the caruncle. This is the area which is outside is a bit vascular, but if you go deep, it is empty. So blocking in this area is less risky, and inferolateral is the area, this one, which is less risky. It gives you more. So here not only the space is wider, this part, but also the structures are very few in this area. So this is the ideal place, and the medial is the ideal place. These are the general entry points that we do for a block. So this is just we talk about. This is we just talk about, and this is the superior nasal, where if you go deep, there are some important structures. So if you want to block here, please limit your depth to 12 to 15 millimeter. Don't go deeper than that. Okay, now this structure, everywhere you go ophthalmic anesthesia, you will find in every book, you will find this photo. And the reason is that we are talking here about the inferolateral block. And for that block, you have to have the eye in a neutral position. We put the patient is on the table like this. We ask the patient to look at this light just on the top. So the eye is in. Sometimes the patient don't focus the eye in one point. Then we tell him, okay, keep your eye like you are driving and looking at the road. So your eyes are still and to the front. This is the best and neutral position for. Now, what you do if a patient have a strabismus? You tell him, look front, and when he look front, the globe go this way. So then you have to give him an angle that is, you rotate your light or hand and tell him to watch. Unless that eye that you are blocking, that come to the center. And then you block. Okay, now this is the primary gaze position, but let's talk about this first. This is up gaze. If the patient is looking up, what happened? The inferior oblique and the inferior rectus muscle comes down, the optic nerve. If the patient look up, the optic nerve, this is the optic nerve, it comes down closer to the floor of the eye. So if your needle is long enough, the nerve is coming in your way. On the other hand, the muscle go away from you. But it happened the opposite. If the patient is down gaze, optic nerve goes up, but the belly of the muscle is now coming in your way. So the best position is the primary gaze. So that is a compromise that you have inferior oblique and you have optic nerve in a acceptable distance. Okay, now this is, you saw this picture. It shows you the relevant distance or gap in comparison to the orbit of the globe. Here, this is how you introduce a needle. The general understanding or recommendation of most places is that this is your eye, you introduce the needle from 120, let's say this eye. So this is a 120 angle. And then while you are advancing, you come to 90, and then most of the patient, if for peribulbar, 90 to 70 degrees, that is the place where you can inject. But if you go deeper for the retrobulbar, you need to come to 60. So 120, 90, and 60. And then you advance. With the angle of 60, you will reach the retrobulbar space. 90 to between 90 and 60, that is the area where you can inject your peribulbar injection. The introduction of 90, it may not be necessary for every patient, but for some patients, okay, let me tell you one more thing that is practiced somewhere. Some people do that. Okay, so now before this is the lower margin of the orbit, and we were dividing it 3 pieces, 1, 2, and 3. We were taking the lateral 1/3 quadrant for the inferior lateral, and we were taking usually the junction, but we don't do that anymore, because now we found, and we have 1-2 studies about it as well, that the more lateral you go, you become not too lateral, not like completely here, but little more lateral than that. We call it a modified inferior lateral. Then you keep away from the muscles that we just talked about. And then the depth wiggle test. What is a wiggle test, and how many people do it? Wiggle test is, some people, when they put a needle, they ask the patient to move the globe. Look up, down, right, left. Why? They want to see if the tip of the needle is somewhere in the orbit, so the orbit will not move. Some people, they practice this wiggle test. We don't. Because my idea is that your needle is, let's say wherever you put your needle in, the needle is in a safe place. And you ask the patient to look right or left, the tip of the needle is there. Before you are safe, but now he brought the globe here, rotated, and he hit. You are not the one to hit the globe. He is the one who hit the needle. So we don't do it, but I don't say either it is right or wrong. If someone is used to it, you can continue it, but just to keep in mind that the wiggle test, to me, I think it is not necessary. It may give you some risk at some point. Now here,
you are considering the skin of the lid 2 millimeter?
you mean the depth? No, the need, this is but okay, this is a good question, and the distance is generally counted from the surface or of the skin. But don't forget one thing, some people, when they block, they indent the skin. For example, you put the needle in, when the whole needle is finished, then the hub of the needle will not go into the skin, but if you push further, the needle will go deeper. We have to avoid that, because in that case, you cannot calculate the correct distance or depth. So in general, we consider it the distance from the skin. Okay, now this will give you some idea. Sorry. Okay, this is how you introduce the needle at a degrees of 120. With 90, you advance, and if you want to go deeper, for example here, this is the angle for retrobulbar block. But we don't do retrobulbar anymore because of its complications. Only occasionally we do it for certain patients. If there is some contraindication for higher volume of local anesthetic, then we do with small 2 cc, 3 cc, we do a retrobulbar. Okay, and this is the point for the medial block. So this is the blind pit between the caruncle and the medial canthal angle. At this level, the space, as we talked in the earlier slides, the orbital and the globe relatively avascular, and caution should be taken because the wall of the ethmoidal sinus can be penetrated, and that wall is very thin, and your needle is very sharp. If you go quick, then there is a possibility you may enter the ethmoidal sinus. One more thing, even not ethmoidal sinus, there are reports that people, they have gone medial, they injected and it came in the nose of the patient, you know. They like a DCR, you know. So there is, what we do, in my practice, you know, I put a needle, especially in the old patient. Young patient, their tissues are stronger, so it is difficult for the needle to penetrate. But for the old patient, you put the needle in, you know, the weight of the needle itself is enough to go by itself. All you need is just to guide. Even you don't need to push it hard. Just guide and it will go by itself. What is the advantage of this way? If you allow the needle to sink by itself, the advantage is that if it go and the tip reach a bone, it will stop. Or it reach a retina, it will stop. Now, what is the diameter of the retina? It is 0.8 to 1 millimeter. So, and you have a sharp cutting needle. If you go to the retina, you will pass the retina, maybe you don't even feel it. Especially now we are using smaller and smaller and thinner and thinner and thinner needle. The more thin is the needle, the more easy it is to penetrate. Okay, now if you go deep in this plane, now see, in the previous slides we saw that this is an area which is very safe, very empty. There are no important structures if you go with the angle of 90 in the medial. But if you go deep, then rectus, medial rectus, optic nerve, and ophthalmic artery. That will come in your way. So for the medial, we don't use depth more than 12 millimeter. That is the shortest needle we use. Sometimes I do this with insulin needle, which is just 4 millimeter long. You don't need to go too deep. You just need to be in a good angle. 4 millimeter insulin needle is enough to inject. What is the disadvantage? It will take a long time because the needle is small, so you have to be patient. Keep a pressure and it will keep going. It diffuse and give you a good block. Okay, now this is the superionasal quadrant. If you want to give an injection here, because sometimes you need a combination of inferolateral and superionasal, or inferolateral with medial. Most of my patients, they don't need a second injection, but in case if they need, I prefer medial. And for the ease, because medial, to make a position, sometime if you are in a hurry and there are too many patients, you have no time, then I give superionasal as well. So this is the superionasal, and you feel for the groove and just go 2 millimeter below and 2 millimeter medial, and that is your point. So this is your surface landmark to feel the orbital, the superior orbital, the groove here. Okay, and again, do not go deep. Now, this is a block which is not used anymore, but I believe, because I've seen few people, they are still using it, but very few. Facial nerve block. Some patients, they are blinking. You given a good block, the eye is okay, he don't feel anything, but he's trying to close his eye because the eyelids are not blocked. A peribulbar block will give you a good block for the eyelids. You don't need a separate block for it. But if you use retrobulbar, because you inject the anesthetic so deep that it does not come to the face, so the patient, in that situation, this was the block was used before, and there were 3 techniques to block this branch of the facial nerve at 3 points. One was Van Lent, which is number 1, blocking at this point, just at the corner. The second was Atkinson, he was blocking it just at the edge of the zygomatic. And then O'Brien he was blocking it just here in front of the pinna of the ear. But we don't do it anymore. Occasionally means, let's say, maybe 3-4 times in a year, I block here. If the surgeon complains the patient is blinking, he put a speculum and he's resisting the speculum. Just put 2 cc here under the skin and that's all. Some people say that put it in a fanning method. Fanning means like you put your injection here, inject here, and then a little this way and a little this way under the skin, and that's all. And it will completely finish the blinking. Okay, ocular compression, I'm sure all of you are doing it. There is every patient, we call it Honan balloon. Put a Honan balloon to every patient unless the surgeon tell you it is contraindicated. For example, a patient have very high intraocular pressure or some retinal reasons, or anyway, if the surgeon tell you, okay, don't use Honan balloon, so exclude only those patients, but use it on all other patients because it helps. Apply it for 10 minutes, not longer than 10 minutes at one session. If you want to keep it longer, then you have to deflate in the middle and then reinflate. So give an intermittent pressure, and the dial, the pressure should not go more than 25 millimeter. Some people, if you put even a very high pressure from outside, it is damaging for the eye. Even the intraorbital pressure, if you raise the pressure more than 45, it can compromise your blood supply to the globe. And okay, and this is a video, just to give a break, and you can watch this video. This is a video for the peripalpal block. So just clean the eye, both margins, and ask the patient to open his eye and look in the front. Keep the eye in a neutral position. If the patient is sedated, sometimes they don't open their eyes. That is another problem. But okay, and now feel, and this is the lateral 1/3. The angle I took is not 120 in this case. It is around 70-80, but you know, based on experience. But for the beginners, I strictly advise to begin with a 120 and gradually reduce. Okay, and then communicate with the patient while you are injecting, because one complication that can happen, that is oculocardiac reflex. We will talk about it in the coming slides. Then in between, if you feel that the ptosis is getting more and the eye globe is getting harder, feel and see if you can inject more or not. The feeling is always it should be in the opposite, not in this direction, it should be in this direction, because if your needle is here and you push it from the opposite side, you can bring the globe closer to the tip of the needle. Okay, and then give 2 minutes, because lidocaine, which is part of this mixture, it takes 2 minutes to start working. So give 2 minutes and assess the globe after 2 minutes. Look for the echinacea. Analgesia is usually, you will see in every patient, but echinacea is not always. So if the patient move a little bit, then you decide whether you need a supplement or not. Keep an eye on the monitor all the time because of bradycardia, possibility of bradycardia. This is a supplement, and this is a superinasal supplement, but the needle, we have to use a relatively shorter needle, and usually 3 to 5 cc in that angle will freeze the eye will be frozen. Again, see now the globe is tight, so finish. I will not give the whole injection, that is enough. And if you check this block now, so you will see the eye is completely frozen. But if I have enough time, I don't use superinasal, I go medial. Now see, now the patient it's frozen. Okay, the next we are going to talk about subtenon, but if there is any question, any discussion until this point. So, yes, sir.
Actually, I have 2 questions. One is, you said that you are using an insulin needle of a length of 4 millimeters. and you advise not to go more than 12 millimeters.
Correct.
Is it not that much far between 4 and 12 that you can deposit the anesthetic in the exact position you wish to block?
Correct.
Number 2 is your position while you are injecting. Which is more correct? Is it to the side of the patient or at the head behind? Just to say to come at the head part of the patient.
Correct. Okay. Thanks. The insulin needle I don't use for primary block. I use it for supplementary block. The first injection I never use insulin because if you inject 4 millimeter, it will come, the whole thing will come to the face. So there will be no block. I use it for medial block because the medial, the place, the superficial place is vascular. If you use a bigger needle, there is no internal bleed, but there will be superficial bleeding. You remove the needle and the eye, you will see there is a bleeding. But if you use an insulin needle, the important thing is not the depth of the needle here. For using insulin needle, it is the gauge of the needle because I want to minimize the bleeding in the medial canthus. But if you have the same size, like 32 gauge, long needle available with you, you can go deeper, no problem. So for the insulin needle, it is the gauge, not the length. 4 millimeter is too superficial, but it is still good if you have a primary injection there. As a supplement, it's fine. It gives you, what happened? Usually the medial rectus is the one which is, for this block, that is blocked the later, or sometime it is not even blocked. You have a good analgesia, but you don't have a good echinacea. So just to block that medial muscle, you see how they do the Botox. Pull the globe and put it just in the area on top of the muscle. Medial block is just something like that. You inject in the vicinity of the medial and then it's spread by diffusion, it goes. The second question was about, sorry.
The size.
Okay, where you stand. I always, for the peribulbar, I stand on the side of the patient. For the superinasal, for the subtenon, it is worldwide the same recommendation that you stand on the left side of the patient, either you blocking right eye or left eye, because your hand angle fits only from the left side. Either if you are right-hander, so right eye and even the left eye like this. So for subtenon, it is always only on the left side of the patient. For the peribulbar, which eye? That side. I don't go at the head side of the patient. But there are people who are blocked from, so I think that is according to the ease of the person, how he feel easy. So is it okay? Can we move to the next? The complication of the peribulbar blocks. There are minor complications and there are major complications. The minor complications are, you can see here, chemosis, very common, especially with the peribulbar, and we know the reason is obvious, and subconjunctival hemorrhage. You will see some small spots, and that is usually because of the pressure of the anesthetic when we inject. It damages the minor capillaries, and you will see these kind of small bleedings. What happened? Here. Okay. So both these complications are not serious. Just a little eye massage or a little Honan balloon pressure, and they stop. The issue is, now this complication, I don't know if you count it minor or you count it major. Oculocardiac reflex. If it complicates and give you trouble, it is a major complication. But it is very transient, and most of the times it goes by itself. So you can also say it is a minor complication. But it is serious. And what is the oculocardiac reflex? This is a reflex which is, three things cause it. We call it 3 P's. What is that 3 P's? Pressure, pain, and pull. You pull the globe suddenly, oculocardiac reflex. You pressurize either by injection or by whatever way you pressurize the globe, oculocardiac. And if you pull either a muscle or the globe itself, so pain, pressure, pain, and pull. This is the reason of oculocardiac reflex. And the trach, where it goes, is by trigeminal nerve, the ophthalmic branch of trigeminal nerve, to the Gazarian ganglion that we just saw. It share fibers with the parasympathetic system. And it give a current to the vagus nerve. The vagus nerve stimulate the heart, and you see a severe bradycardia, system-wise vasodilation, reduced cardiac output. If you don't treat immediately, the patient can go on cardiac arrest, asystole. In my practice, I have seen asystole many times with oculocardiac reflex. So this is now how we treat. I will show you the pathway of this in the next slide, but how we treat. The treatment is very easy. The easiest thing and the simplest thing that you can do is what? Head down position. Bring the table quickly, head down, to bring the flow of blood to the brain, because patient is vasodilated. When you restore the flow to the brain, the patient wake up. Then the treatment is mostly supportive. I'm sorry, I'm making this mistake again and again. Okay, IV fluid, oxygen, and this is the treatment. Atropine, 0.5 to 1 milligram, stat IV. Patient will regain the rhythm and everything within a minute. But occasionally, it can take a long time, or if atropine fails, don't hesitate to give adrenaline, but not 1 milligram. 0.1 milligram. 1 milligram epinephrine diluted in 10 cc, inject 1 cc out of that diluted solution. Usually that 1 cc is enough to return the heart rate. If it doesn't work, inject 1 more cc. And most of 100% result. And this is the pathway. Short ciliary ganglion, Gazarian ganglion, and here it shares the fibers with the parasympathetic system, and that stimulates the vagus nerve, and you see this oculocardiac reflex. Now, let's talk about major complications. Hemorrhage that we every day, this is the main thing that we are worried about. And hemorrhage, again, it depends where. Peribulbar, subcutaneous, retrobulbar. The worst is retrobulbar. That is why we do not use retrobulbar block anymore. And what is the main problem? You increase the pressure in the posterior chamber, it will occlude, the pressure will become so much that it will occlude the central retinal artery. And you will have ischemia of the globe. So it can damage the eye within seconds. Brainstem anesthesia, as we talked in the earlier slides, that is a devastating complication. Either sometime you inject in the muscle. There are reports people, they inject the muscle. Or you inject a high concentration very close to the muscle, and that high concentration give a transient myotoxicity and globe perforation. Now, our globe perforation ratio is much less, but this is what with the peribulbar and retrobulbar combined, 0.75%. This is a very high percentage. It's almost 1 patient out of 100 blocks. So this is a serious thing, something serious. Where is that brother? Oh. And retinal detachment. The retinal detachment can be a complication of your globe perforation as well. Retina is very thin, it's not very, in the camera it looks big, but it is less than 1 millimeter thickness. But the perforation is mainly 3 types. If you perforate the globe, either you go into the globe and you inject inside the globe. That will give you hemorrhage, and there are major complications. The minor complications are, you can see here, chemosis, very common, especially with the peribulbar, and we know the reason is obvious, and subconjunctival hemorrhage. You will see some small spots, and that is usually because of the pressure of the anesthetic when we inject. It damages the minor capillaries, and you will see these kind of small bleedings. What happened? Here. Okay. So both these complications are not serious. Just a little eye massage or a little Honan balloon pressure, and they stop. The issue is, now this complication, I don't know if you count it minor or you count it major. Oculocardiac reflex. If it complicates and give you trouble, it is a major complication. But it is very transient, and most of the times it goes by itself. So you can also say it is a minor complication. But it is serious. And what is oculocardiac reflex? This is a reflex which is 3 things cause it. We call it 3 P's. What is that 3 P's? Pressure, pain, and pull. You pull the globe suddenly, oculocardiac reflex. You pressurize either by injection or by whatever way you pressurize the globe, oculocardiac. And if you pull either a muscle or the globe itself, so pain, pressure, pain, and pull. This is the reason of oculocardiac reflex. And the trach where it goes is by trigeminal nerve, the ophthalmic branch of trigeminal nerve, to the Gazarian ganglion that we just saw. It share fibers with the parasympathetic system, and it give a current to the vagus nerve. The vagus nerve stimulate the heart, and you see a severe bradycardia, system-wise vasodilation, reduced cardiac output. If you don't treat immediately, the patient can go on cardiac arrest, asystole. In my practice, I have seen asystole many times with oculocardiac reflex. So this is now how we treat. I will show you the pathway of this in the next slide, but how we treat. The treatment is very easy. The easiest thing and the simplest thing that you can do is what? Head down position. Bring the table quickly, head down, to bring the flow of blood to the brain, because patient is vasodilated. When you restore the flow to the brain, the patient wake up. Then the treatment is mostly supportive. I'm sorry, I'm making this mistake again and again. Okay, IV fluid, oxygen, and this is the treatment. Atropine, 0.5 to 1 milligram, stat IV. Patient will regain the rhythm and everything within a minute. But occasionally, it can take a long time, or if atropine fails, don't hesitate to give adrenaline, but not 1 milligram. 0.1 milligram. 1 milligram epinephrine diluted in 10 cc, inject 1 cc out of that diluted solution. Usually that 1 cc is enough to return the heart rate. If it doesn't work, inject 1 more cc. And most of 100% result. And this is the pathway. Short ciliary ganglion, Gazarian ganglion, and here it shares the fibers with the parasympathetic system, and that stimulates the vagus nerve, and you see this oculocardiac reflex. Now, let's talk about major complications. Hemorrhage that we every day, this is the main thing that we are worried about. And hemorrhage, again, it depends where. Peribulbar, subcutaneous, retrobulbar. The worst is retrobulbar. That is why we do not use retrobulbar block anymore. And what is the main problem? You increase the pressure in the posterior chamber, it will occlude, the pressure will become so much that it will occlude the central retinal artery. And you will have ischemia of the globe. So it can damage the eye within seconds. Brainstem anesthesia, as we talked in the earlier slides, that is a devastating complication. Either sometime you inject in the muscle. There are reports people, they inject the muscle. Or you inject a high concentration very close to the muscle, and that high concentration give a transient myotoxicity and globe perforation. Now, our globe perforation ratio is much less, but this is what with the peribulbar and retrobulbar combined, 0.75%. This is a very high percentage. It's almost one patient out of 100 blocks. So this is a serious thing, something serious. Where is that, brother? Oh. And retinal detachment. The retinal detachment can be a complication of your globe perforation as well. Retina is very thin, metabolized and taken out from the body. So there is no other treatment. The treatment is generally, it is supportive. And the most important thing in the supportive treatment is the control of the airway. Once the patient loses the control of the airway, so then you need an anesthesiologist or intensivist beside you so that he can intubate the patient, put the patient on a ventilator, give him inotropic drugs, support the blood pressure, support the vital signs, and wait until the drug is metabolized and gone out. Now, myotoxicity, we already talked about it, and hyaluronidase is a good component of the anesthetic mixture. If you don't use hyaluronidase, the possibility of myotoxicity is more, because the spread or distribution of the local anesthetic is important too, so that it goes all around the globe. Many patients can come after cataract surgery or many other surgery. After 1 week, 2 weeks, they come to the ophthalmologist with diplopia. And then they realize that the problem was because of the block, of the myotoxicity, or a direct injury to the muscle. Now, how we prevent this? We already talked a little about it, but this is how we should do. Don't go deep and take precautions to avoid injury. And the local anesthetic, some centers they use 4% lidocaine. That is toxic to the ocular muscle. So don't use too concentrated local anesthetic. Usually 2% is give you a good block. Now, the complication of topical intracameral, we think that probably this is topical have no complication. Yes, it has very little, but still it gives you some complication. For example, when you put it in the eye, patient, it's stinging feeling. But if you use excessive amitocaine is a trade name, basically this is tetracaine. If you use tetracaine or binoxynate too much, it can cause the epithelial edema, intraocular. So there is a limit to use this as well. Intracameral, the same. Usually 1% lidocaine is used. And how much amount usually you use intracameral? How much the intracameral place accommodate? Not 1 cc. It's too much for the intracameral. 0.1 to 0.2, the maximum 0.3, not more than that. And that gives you a good anesthesia for the surrounding tissues. Okay, now this is our own study. This study we performed 2003 to 2009 in KKH. And we studied 33,300 patients for complications of the anesthetic blocks. And we found 41 cases of complications. There is a possibility maybe some patient is missed, we don't know that, because this was a manual study. At that time we didn't have the computerized. Now we have computerized one. The systemic complications were 18 out of 41, and the needle-related complications were 23. But imagine, KKH is a center, it's a tertiary care hospital for eye, and it is one of the biggest hospital not only in Saudi Arabia, it is one of the biggest hospital in the region. And the people working there are working for a long, long time. So, well, I'm not trying to say that we are very good, but what I'm saying, we are experienced. We are working there for, and many other my colleagues, they are very experienced. And they have been working for a long time. So it make a difference. That if you perform the same study in a general hospital, you will find the complication rate high. Now, this was also we found in this study, the oculocardiac reflex, we found 16 cases. Central spread, we found 1 case, and stress-induced epilepsy was 1 case, but this central spread patient, this patient, he lost his consciousness. And then we had to resuscitate him, and we kept this patient in HDU for 24 hours. Finally, the patient recovered, but it was a serious, and it happened with a retrobulbar block. Now, the globe perforation in 2003 to 2009, we have 8 cases of globe perforation. But remember, our per year average is more than 10,000 cases. So still it is a very, very, internationally, it is 0.026%. Internationally, it is less than around 1%, 0.75%. Hemorrhage, retrobulbar, 5 cases. Lead hematoma, 5 cases. Optic nerve damage, 1 case. And this patient was the same patient who had a central spread, the one you saw in the previous chart. So this patient, the patient recovered, but his vision was gone. He did not recover, he became blind in that eye. After 2 weeks with treatment and repeated visits, and he regained some vision to hand motion and light perception.
Is because that the patient is moving or because of the technique?
I think movement I don't remember, but probably technique related.
It's not...
This was a retrobulbar block.
I mean, it is not written that time in the report.
No, because that time nobody knew what happened.
Oh.
But it was a retrobulbar block, a long needle, and I'm sure what we discussed, the same thing happened. Probably it was a subarachnoid injection, and so patient lost his consciousness immediately, but at the same time the optic nerve was also damaged. And that is why this patient, he regained the vision, but probably when the inflammation settled down and after treatment, but not a full vision. Now, I think I have 15 minutes more. Probably it's too long, but if any question until this point, we can talk about it. Okay, so let's talk about subtenon block. Now, subtenon block is replacing peribulbar and retrobulbar completely. Worldwide popularity is gaining because of its very, very low rate of complication. And I'll just tell you a little bit. This is we see the globe, and this is the tenon capsule. You see the muscles, the rectus muscle here, they coming from behind, and they enter the tenon capsule and they insert on the globe. Right? So in another way, you can say that they are traversing the tenon capsule. The tenon capsule, it's a fibrous and it is elastic tissue, which surrounds the globe at the back. In the front, it joins your conjunctiva. So that is why we approach this space through the conjunctiva. We don't go too deep to put the needle here. We approach it usually from the conjunctiva side. Okay, and it covers the globe from behind up to the optic nerve. And the space interior, the capsule, it is adherent to the scleral tissue, and as I said, it extends from the limbus posteriorly, approximately 10 millimeter from the limbus of the eye. And the important thing to know is that this tenon capsule, all this, the ciliary nerves and the other structures which enter the globe from behind, they pass through the tenon capsule. So if you block the tenon capsule, you block everything which enter the eye. Here, it is not a real space. It is a potential space. And so when you inject in the tenon capsule, we have peribulbar, we inject with a high speed, no problem, because it will spread around. Tenon capsule, you have to inject very slow, because you have to create a space. You have to separate the layers to create a space. And delivery of local anesthetic into this space allows spread along the extraocular muscle sheet. Retrobulbar space, it diffuses from the tenon capsule to the back. It spread into the facial planes around the lids, and then it has direct action on the nerves those are supplying. So now, anesthesia can be performed by two ways. Either you block the muscle. The muscle and the nerve, they work on the same mechanism. Both have action potential. What the local anesthetic does, it blocks the sodium channel. So there is a sodium channel in the nerve, there is a sodium channel in the muscle as well. It blocks both. So if you put, there is no nerve supply, but you inject in the muscle get paralyzed. Or you block the nerve which is supplying that muscle. So again, you can block the muscle. Here what we do, in the eye, we block both. We block the nerve, and we also block those muscles which are supplied by those nerves. Okay, just to show you this, I took it from a review article, but I just summarized it in a small table. Advantages and disadvantages. Virtually painless means no needle. Always the patient come for eye surgery, he is afraid of the needle. You tell them no needle. So that relieves the anxiety of the patient. It gives you excellent analgesia, good echinacea, and you can avoid all the complications, major complications which are related to the needle block. Anticoagulant patient on warfarin, no problem. Patient long axial length, this is the block of choice. You don't need a facial block. Same like peribulbar. And serious complications are very rare. And the increase in the intraocular pressure is very, very little. Wa alaikum assalam wa rahmatullah, Dr. Fahmi Hawari. Then disadvantages. It's same, but those are minor. Chemosis and conjunctival hemorrhage. This thing, we have to be careful. Pterygium and scleral buccal. Pterygium patient, because that patient may bleed, and the scleral buccal patient, if we don't know the history and we try to go to the tenon capsule, the needle is not going, you can perforate the globe. And then use aseptic technique. Peribulbar, because you enter through the skin, but here you are make sure you don't introduce any infection into the tenon capsule, otherwise the patient will come back with the endophthalmitis. And side-threatening complication with the subtenon block is very rare. And let me show you the subtenon block first, and then we can how to run this video. Yeah, thank you. Again, clean the eye from outside, same like we are cleaning for the peribulbar block, because because this is a sterile procedure, so you need to have a sterile gloves. And so clean the eye from outside first. Put some binoxynate or methocaine drops so that give you a good surface anesthesia and allow the needle to enter without pain. And also put a drop of iodine just to clean the eye from the surface. And while the binoxynate is working, you can fill up your syringe. Usually you need 5 ml, the most you need. You don't need more than that. 3 to 5 ml give you, and look, is this needle, this is a steel needle, but it is not sharp. It is blunt needle, and it is not round, it is flat. This is called Steven needle, but there are many other types also available in the market. Put a speculum, put some more, this is iodine, put a drop of iodine. And then, this is right eye, ask the patient to look at the angle here, put a torch here, so that he fix it, so that he give you some space here. Let's say this is around 10 o'clock. Raise the conjunctiva with the complete thickness and make a small cut, which is just enough to allow this needle to go. Now advance this needle and sliding movement like this, like the worm going in like this, and make sure you go tightly adjacent to the contour of the globe. That is important. There is one thing important here. How you know that you are in the tenon capsule? Many times you inject and it comes under the conjunctiva, subconjunctival. So usually those colleagues who are anesthesiologists, they will know it better. Like we do in the epidural anesthesia, there is a technique we use, a loss of resistance. The same thing is here. There is a loss of resistance. When you go, if you go tightly close to the globe, to the contour of the globe, a point will come that you feel resistance. And if you push a little hard, suddenly the resistance is gone. That means that you enter the tenon capsule. And then that is the place where you inject. So that is the technique for the, but it is, for safety wise, this is the best block. It has some complications. Yes, please. How much to go? This needle that you saw here, this is 26 millimeter long. But usually this needle goes inside about 2/3. But there is no harm if you go behind. It's not a problem. The important thing is your angle. Because what we do, usually we go between inferior rectus and medial rectus. We take the middle of it. So inferior rectus, medial rectus, we take that angle. If you move your angle here and there is a possibility you can damage either the medial muscle or you can damage the inferior muscle. So just keep in the middle of both. You can go as far as you want, it's not a problem. But you don't need to go, once you enter the tenon capsule, that's all, you inject. It is a potential space, you are injecting slowly and it will spread and it will make a gap and it will spread by itself. Now, this was a big study which was published in 2012, and they were looking for the complications of the worldwide complication of the subtenon block in comparison to the retrobulbar and peribulbar block. And they found here 2 reports of retrobulbar hemorrhage from the subtenon block. They found central spread in 2 cases, and they found orbital cellulitis in 2 cases.
How much is total of the study?
Total, I don't remember exactly, but it was a multi-center and huge study. So what they did, they collected, I think it will be difficult for them even to know how much, but they collected worldwide reports. And scleral perforation was one report. Hyphema and ocular massage is considered in the subtenon block as a relatively, they say don't do a massage. We do it for peribulbar, for retrobulbar, gentle massage, but for this, because they say massage can transiently increase your intraocular pressure, sometimes too high. Sometimes you ask a nurse, can you do like this? And she pressed while the globe is already tight, she can, even we can do that mistake sometime. And here, the extraocular muscle paresis have also been reported, but they are transient and usually recover within few days. Here, remember, we are putting the local anesthetic much closer in the vicinity of the rectus muscles in the subtenon block in comparison to the peribulbar block. Because all the muscles, they enter the tenon capsule and insert in the globe. So once you block the tenon capsule, all those muscles will get a significant amount of local anesthetic. So probably this is one of the relatively disadvantage of this block. Okay. And again, hyaluronidase, we strongly recommend to be used. I show you 2 studies here. This is again, that is about side-threatening complication of subtenon block. And this study here, you can see the number. 161,000 patients having subtenon block. This was British Journal of Ophthalmology 2007 report. And they found less than 0.6 per 10,000 patients had side-threatening complication. In peribulbar, it was 2.9, and retrobulbar, it was 4.5. So the least complication is with the subtenon block. Another study, this is a multi-center, and the subtenon block, the complication rate was 5 per 10,000. But for peribulbar, it was 12 per 10,000. This was published in Eye Journal in 2009. And these are the minor complications, which were more common in the peribulbar block. Okay, DCR we do also under local anesthesia. I didn't bring any video for that, but I will not go in detail, just briefly tell you that there are patients who are not fit for general anesthesia, and you need a DCR. What you do? You do a local. The technique that we use for DCR is simple, but we found it effective. And it minimizes the intraoperative bleeding. Again, patient stays reduced and the cost is reduced if you do it under local. This is what we do we pre-medicate all the patient with hydroxyzine and paracetamol tablet. Hydroxyzine is sedative and anxiolytic, both. So we use about 25 milligram to 50 milligram for the older patients. We give a topical anesthesia to the eye with tetracaine, clean it with pyridine, and we do a medial block for the DCR. You saw the needle for the medial block. In the peribulbar, we do it as a supplement. Here, we do it as a primary block. We don't give inferolateral, we give a medial block, 5 to 10 cc, peribulbar, medial peribulbar. It gives you complete anesthesia of this side of the nose. And then you supplement it with the nostrils with the 4% lidocaine. That is a high concentration lidocaine because we want a good anesthesia for the nasal side. And then we pack it with a vasoconstrictor. And usually, this is more than enough. Occasionally, it may happen the patient start complaining during the procedure, a little pain. So then we give him sometime a little systemic fentanyl or sometime a little pethidine, morphine for more sedation and some systemic analgesia. And you may end up sometime to use a small dose of propofol as well, especially when the patient is, when the surgeon is cutting the bone. There is a possibility the patient may complain because that's too deep, maybe not block well. That time, sometime we do installation of local anesthetic on the top of the bone. We tell the surgeon, we give him a swab which is soaked in the lidocaine, we say, put it on the bone. He put it in the bone for 1 minute and then he can continue his work. But generally, local anesthesia for DCR, it works very well. Now, some relative contraindication for DCR under local. For example, here, presence of this infection and fluctuant mass over the lacrimal sac. But this can, DCR local block can also give you side-threatening complication. How you assess a block? I think this method is universally the same. I think there is no difference. We compare the block eye to the non-block eye, and then we look for the moment. Immediately we cannot assess the analgesia. Let's not confuse analgesia with echinacea. Echinacea, if a patient have echinacea, definitely he has analgesia. But if a patient do not have echinacea, that does not mean he does not have analgesia. The patients have no echinacea, but they have good analgesia. Why? All the local anesthetics, they block the sensory nerves first. The motor nerves are blocked later. Sometimes the motor nerve are not blocked, but that they still have good analgesia. So if a surgeon is doing cataract, if the eye is moving, no problem, as far as the patient don't feel it. But younger patients, they are usually challenging because their eye is compact, the tissues are tight, the spread of the local anesthetic around the eye is difficult in comparison to the older patient. This is what the local anesthetic combination that we use in our center, but this is not the one in the final. Many people use different combination, all are okay. Even you can, for shorter cases, you can use only lidocaine 2%, that is more than enough. But this is our formula that we use in KKH. Let's say this is 5 cc. In 5 cc, we take lidocaine 2%, 2 cc. And we take bupivacaine 3 cc. And we mix it with hyaluronidase 25 units.
Per mil or total?
Total for 5 cc. This means 5 unit per mil. But again, hyaluronidase is a drug with a wide therapeutic index. That means it is a safe drug. You can use starting from 5 units per cc up to 50 units per cc, no problem. Even if you go up to 100, I have seen in the studies were not about hyaluronidase, something else, but I have seen people are using it up to 100 units per cc. So it's a safe drug. If you want to use more, we have a good result with 5 units per cc. For the local, we use tetracaine or bupivacaine or oxybuprocaine, which is binoxynate, and we combine it with a lidocaine 2% gel. So this is how we use it. Thank you very much, and open for discussion. Yeah. Thank you.
طيب بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. اللهم صل وسلم وبارك على سيدنا محمد وعلى آله وصحبه وسلم. Assalamu alaikum, and a big welcome to our last workshop, inshallah, today. It's named Fundamental Vigilance of Ophthalmology Drugs and Instruments. In the sheets you have, there is a pre-test which we would like you to take before we start the session, the first session. You don't need to write your name there. We're going to repeat this pre-test at the end of the workshop again, just for us to see the gain of the knowledge after that. It will be in the very last paper في الشيت. Just take 2 to 3 minutes to finish this pre-test. Okay. بسم الله الرحمن الرحيم. السلام عليكم مرة ثانية. And welcome to this workshop. On behalf of the Faculty of Medicine Al-Baha University and on behalf of the Dean of the Faculty, Dr. Ali Hind Al-Ghamidi, who apologizes today to attend, we would like again to welcome you to this workshop, which will have 2 components, the theoretical component and some touch of practical components, because it's extremely very difficult to conduct a very full practical component in 1.5 hours. So it will be very short for this particular part of the practice. What we are aiming for by today, we are aiming for 5 important objectives. The first is, we should be very clear about what do we mean by these terminologies. Pharmacovigilances, ADE, adverse drug events, and adverse drug reaction. The second objective is we should set a floor to why it's really important to know these terminologies and to practice it. And we'll put some emphasis as well on the ophthalmology practice. The third part will be about who should report. Okay, we should be clear about who should do the reporting. And the objective before the last is what happens to the report once you report it. And the last part of the objectives is how could you report a drug reaction or events whatsoever. So hopefully by the end of this workshop we'll be able to gain these 5 important objectives. It gives me a very good pleasure to present the presenters who will present this workshop for today. Dr. Ali Hind Al-Ghamidi, he is a senior consultant ophthalmologist, Faculty of Medicine Al-Baha. And the main presenter of this workshop is Dr. Salah ad-Din Abdul Haq. Dr. Salah is a PhD holder, is MBBS as well. He is an associate professor of pharmacology or clinical pharmacology, Faculty of Medicine Al-Baha. Dr. Salah has extensive work on pharmacovigilances. He is one of the national committee members in Sudan of pharmacovigilance and adverse drug reaction report. And the second presenter is Dr. Ayman Abdul Ghaffar. Dr. Ayman Abdul Ghaffar, again, he's an associate professor of pharmacology, and he's currently in Faculty of Medicine Al-Baha University. Dr. Sami Asil or Dr. Mahdi Bashir. Dr. Mahdi is a consultant ophthalmologist, and Dr. Mahdi is having a special interest in pediatric ophthalmology. Dr. Sami Asil is an assistant professor of community medicine, and last myself, Dr. Haytham Al-Binjawi, I'm consultant physician and associate professor of internal medicine. So those will be involved, inshallah, in conducting this workshop for today. I would like to present Dr. Salah for the first talk, which will be taken, inshallah, 10 minutes time, inshallah. Tafadhal, Dr. Salah.
I would like to welcome you all again. And I would like to thank Dr. Haytham for this generous introduction. I will give you a summary and a sum up of the activities and the scientific basis of this regulatory issue of pharmacovigilance. The WHO defines pharmacovigilance as the science that relates to the detection assessment, understanding, and prevention of effects, adverse effects of drugs or any other drug or device-related problem. Detection, assessment, understanding, and then prevention of these adverse effects of drugs and devices. This is the formal WHO definition of adverse drug reactions. Pharmacovigilance have extended and flourished to include many new areas, including herbal pharmacovigilance, herbs and herbals pharmacovigilance, traditional complementary medicine vigilance, blood product vigilance, devices and vaccines vigilance, which are topics in this workshop or seminar. There is an overlap some people think that adverse event or adverse drug experience or adverse drug reaction are synonymous, but they are not. When an adverse effect is thought to be caused by a drug and reported, this is called an adverse event. When the causality or causality between the drug and the event have been investigated and established, this is called truly adverse drug reaction. When it is reported as an adverse event and it goes to the reporting port, it is regarded as a signal. Multiple signals will stratify on each other to onset an investigation. When this investigation establishes a relationship between the drug and the event, this is called adverse drug reaction. Pharmacovigilance as general depends on the so-called adverse drug reaction reporting. This is the core of pharmacovigilance. And it is called a spontaneous reaction because it is not triggered by any other factor other than self-motivation. It is called a spontaneous adverse drug reaction reporting. The importance of spontaneous reporting to the discipline of pharmacovigilance is that it provides quality and quantity of reports. The second, it is an inexpensive method to detect adverse drug events or adverse drug reactions. It provides a new and fresh information, day by day experience, which were not known to have or related to these drugs. Yani it contributes to the safety profile of the drug or the risk profile of the drug. Another importance, which we may not like very much, it is a legal obligation to report adverse drug reactions, especially if it causes casualties. إذا كان permanent disability or fatality or death. It is, for all these reasons, pharmacovigilance activities regard the spontaneous reporting as the cornerstone of this discipline. It is a cornerstone of this discipline. Of particular importance in the activities of adverse drug reaction reporting is reports that in which are involved special patient populations, including children, pregnant females, elderly patients, and multiple patients with multiple comorbidities, patients with multiple problems, and patients with unique traditions or unique diet habits or dietary habits. And last but not least, patients with particular or of particular ethnic group. Patients with particular ethnic groups. I would like to ask you, why do you think these special patient populations are important? Why do you think these special patient populations are important? Yes?
They are more susceptible to be exposed to the risk.
They are vulnerable.
Yes.
Vulnerable. And? Yes? I would like to hear from you. Why do you think these patients are important? Because during the clinical trials on drugs, these patients are excluded from these clinical trials. You cannot do a clinical trial of a new drug to establish a safety profile on a child or on a pregnant female or in a patient with a comorbidity or using multiple or polypharmacy. Okay? واضح الكلام? Therefore, their safety profile for these special patients is established post-marketing. بعد ما الدرج ينزل السوق وكده حتى بعد ذاك لو في أي adverse or risk will be of high importance. Yes? Next. Importance of pharmacovigilance in ophthalmology practice. There are two contributing factors to this. First, we consider the eye as the window to the body. A vigilant ophthalmologist will report adverse drug reactions of drugs administered for systemic diseases, in addition to drugs used for ophthalmic indications. Therefore, he have a dual or a doubled responsibility to be vigilant and to report of adverse drug reactions, and we will show some of the reports that have been reported by ophthalmologists of drugs that were used for systemic diseases and have adverse drug reactions that were apparent on the eye. The adverse drug reaction was apparent on the eye for drugs used for systemic diseases. Examples include alpha-1 adrenergic antagonist, tamsulosin, which are usually used for benign hyperplasia of the prostate, have caused intraoperative floppy iris syndrome, the so-called. Tobramate, which is a CNS acting drug used for epilepsy, migraine, and bipolar disorder, has been reported to cause myopia and angle closure glaucoma. Rifabutin, which is a Mycobacterium avium complex disease used for respiratory infection in patients with AIDS, mostly in patients with AIDS, have been reported to cause uveitis and corneal endothelial deposits. Cetirizine is a drug used for antihistaminic drug used for allergy, has been reported to cause oculogeric crisis in the pediatric age group. And bisphosphonates, which are supplementation, used in osteoporosis, Paget's disease, hypercalcemia, multiple myeloma, and so. It has been reported to cause uveitis, conjunctivitis, and side-threatening scleritis. And glucocorticoids are reported or known to cause glaucoma, and so on. More anti-cancer chemotherapy, docetaxel, and so, and كده. They are reported to cause painless glaucoma, lantoprost, bimatoprost, and so on. Okay, are reported to cause glaucoma, are used for glaucoma and reported to cause cystoid macular edema. Digoxin, the cardiac glycoside used for heart failure, is reported to cause impairment of color vision. Phosphodiesterase 5 selective inhibitors, sildenafil and so, used for erectile dysfunction, are reported to cause non-arteritic ischemic optic neuropathy. Linezolid, which is antimicrobial used for methicillin-resistant Staphylococcus aureus, is reported to cause toxic optic neuropathy. And amiodarone, we know it is antiarrhythmic. Isambutol, it is a mycobacterium antibiotic. And interferon, used for hepatic viral hepatitis, are known to cause optic neuropathy. All these reports were reported by ophthalmologists in their ophthalmic practice. So, one of you will ask, so what is the problem? It's good. We as ophthalmologists or we as practitioners should report. So what is the problem? The big, massive problem is underreporting. Drug sales worldwide are supposed to be around $350 billion per year. And the reports are very, very, very scanty. Very, very small number of reports are reported every year. So there is a problem with underreporting that is globally identified. This study was conducted in 2013 in the Middle East, pharmacovigilance in the Middle East, a survey of 13 Arabic-speaking countries by someone, Kerry Wilper or so. You see these dashes? These dashes? These are Bahrain, Egypt, including Lebanon, KSA, 13 countries in the... All these dashes indicate that there are no enough or adequate pharmacovigilance activities in these countries. What are the causes for underreporting? Doctor-related causes identified as lethargy, uncertainty about what will happen if I report. So what if I report? What will happen? Nothing. One report will change nothing. Uncertainty, difficulty in diagnosing ADRs. Some of the practitioners will not identify that this is adverse drug reaction. Yes. Drug-related factors include patients using multiple drug protocols. For example, anti-tuberculous protocol. That includes 4 or 5 drugs. It is difficult to identify which drug caused the adverse drug reaction. These are so-called and counterfeit drugs. Drugs that are, yes. Patient-related factors include self-medication, patients using drugs at home, and patients who with poor follow-up visits. Yes. The accepted norm is that reporting is mandatory in many countries around the world. In Sweden, Netherlands, and Portugal, patients, not practitioners or ophthalmologists, patients from the community can report ADR. In the Netherlands, medical and pharmacy students also can report ADRs. This is a study in a European study that have included more than 800 medical students from 8 leading faculties of medicine in Europe. The respondents replied that or admitted that if they detected an adverse drug reaction in the future, 70% of them will search for additional information because they think they do not have enough information or skill. 47% of the Respondents said that they will search, they would conduct a literature search. 33% admitted that they would withdraw the drug. 21% said that they will ask a supervisor help. 22% said that they will take action. And only 16% of these practitioners admitted that they would report the ADR. Among third-year students and sixth-year students in these medical schools, 56% of the sixth-year students said that they don't know where. 56% of the third-year students said that they don't know where to report. They said, I would search the literature to know where to report. 22% of the sixth-year students who are practitioners for 2 years said that they don't know where to report, although some of their colleagues have reported once or twice. 90% of the third-year medical students don't know the necessary items of a valid adverse drug reaction report. ماذا يكتبون في adverse drug reaction report? They don't know. Back, please. And 66% of the sixth-year students said that they don't know the necessary information to be written in an adverse drug reaction report. Meeting the requirements of a valid adverse report, a valid adverse drug reaction report is, it has 4 components. Identifiable reporter, not necessarily a name, an email address or a telephone number or whatsoever to be to a relay point. Identifiable patient, not necessarily the name. Age, sex, age group, national health number whatsoever. Identifiable drug, this is very important. Identifiable drug, it must be a brand name or a generic name that can be traced back to a specific manufacturer, or a drug with a route and a dose and a specific criteria that can be traced back to a specific producer. And last, an identifiable adverse event. These are the 4 requirements of a valid adverse drug reaction report. Thank you very much.
طيب بسم الله الرحمن الرحيم. Assalamu alaikum everyone. Lovely student, lovely doctors. You are welcome here for this interesting topic. And I think it is very helpful and we get maximum benefit in the ophthalmology field in relation of this topic. Okay, it is a huge revolution now in devices and technical products in the ophthalmology field. It is a revolution every day, as you see in the company shows here in the conference. It is a very huge revolution. Every day there is a new product or device in the ophthalmology. Okay, in the ophthalmology field. You can revise here these things. For example, the cataract field. As you see, this is a phaco. You know, few years the phaco was a very modern procedure and apparatus, but today phaco is the main cataract surgery procedures, and the competition between the companies, you know, it is very hot. It's very hot, you know, phaco machine, infinities, every now and then. And the device is also implant, intraocular implant device like IOLs, intraocular lens, also enter this competition, this hot competition. As you see here, a lot of types of intraocular lens devices, and the perimetry itself you know, and the equipment and instruments and the measures in the cataract field is very huge. This is aiming for an introduction of our, you know, this topic. This revolution in production should be controlled. لابد انه يكون في failure, لابد انه يكون في feedback reports, as we'll see here. Okay, for example, here also the laser, the implementation of laser, yak, excimer, and argon laser. Every day we have a new, as you see here, Alcon and also Nidic. They have new, you know, apparatus here in the show. You know, the implementation of LASIK now, and the corneal rings now, it is a practice. It is intraocular practice, and you know, a new design of lenses. IOB now is taken automatically with you know, eye care tonometer, these kinds, and the Avastin injection, you know, to inject Avastin or Lucentis intravitreally. Now it is practiced in retinopathy and new vascularization, even in new vascular glaucoma, as we know. Now it is practiced. Here you see the refractive surgery, new and very sophisticated machines, as you see here. This is Visumax and others you will see, and this microkeraton and other devices. This is a new, you know, thing. You may be very surprised for me and ophthalmologists and others. The micro intraocular implantation of devices like this. Here I put these pictures or images to compare the, you know, fingers, the tip of the fingers with this device. This device is now routinely implanted in the retina or in the vitreous or in the choroid or subtenon or subconjunctival. Some of them are long or slow acting, you know, like this dexamethasone. Dexamethasone, now we are not going to inject just the intravitreal dose of dexamethasone. This is a simple device. You can inject this, you know, slow releasing dexamethasone for long time, you know, before, and you can put, before this, and here is more releasing also, also anti-cancer drugs for malignant melanoma, for retinoblastoma can be implanted for small releasing of chemotherapy or something like that. Here you have, you know, valves, the shunt operation. It was Ahmed valve with, as you see, as with tube and a bit tube. Now it is like this. Here in Epiphora, you can put the plug as you want for 1 year, 2 years, whatever, depending on the classification of the epiphora itself. Before قبلها. Also, here you have also a lot of types of anti-VEGF and dexamethasones and anti-cancer and others and valves. Next. You know, the technical companies now introducing seriously in the ophthalmology, you know, devices, and now they are putting things which are amazing, as you will see here, amazing things, you know, implanting cameras, wireless cameras, like Google, what Google doing here, something, and now making contact lens camera. You are not going to take your mobile or implanting something. You can put now the hidden camera as just contact lens in your cornea, and you go and everyone can see. You can enter conference, security, or unpermeable areas anywhere, and your camera is as a contact lens like this of Google. This is production of Google, and this is a valve, a small valve, and this is a complete eye with شوف اللي بعدها حبة شوفها with its cables. You know cables, just like cables. This is a complete eye. This cable can be connected to the eye, to the neural or the optic nerve, something like that, and can transmit, as we'll see. قبالة القبلة لا القبلة حبة القبلة نعم 3 minutes حق الصلاة ولا زيادة. طيب هنا كمان واحد كنديان، هذا ابراهام، هذا من كندا، بيتحدى وبيطلع الان في اعلانات بيقول انا عملت اي او إلز، لسه ما نزلت لكن هو بيقول كده في صفحته انه عمل الاي او إل بالانجكتر بتاعه هنا، وبقول انها المريض his patient cataract patient he will see 3 folds in 2020. He said so. And all people now they are looking what type of this intraocular lens making the patient, cataract patient, see more than 20/20. 20/20 is 6/6 as we know, 6/6. He said that there is magnification, there is accommodation, there is something like that, but we are working here. Retinitis pigmentosa, as we see what is happening. This is a jump for blind and hopeless patient of optic nerve atrophy and retinitis pigmentosa. Now, you know, this is the, device, this device with external connection with cells, these cells, and the eyeglass, and this apparatus, where is it? كده قبالة قبلها, and this one, أيوه, ثاني أرجع. This one, and they can see. They can see. Now they have hope, blind patient, they have hope, and they can see, as we see here, the cells, how can be connected to the brain.
Disadvantage of all these devices?
Yes, I will come to that. Okay. Finish? No, one before. Here, these are therapeutic contact lens, instead of giving some drugs or eye drops, we can giving that way. This is an American revolution now. This is ocular telescope. Now manufactured by some American companies, and they are going to implant this telescope, not eyeglass or something device like that. Okay. Here, this device vigilance, some of them are reported and covered by the protocol, like all these implants and advanced life support and others, and some till now are away, not covered, uncovered by the protocol بتاع الفيليجنس اللي هو زي البايو ساينس هنشوفها بعد شوية. Some of them covered, some of them are not covered. Type, we have drug-device combination. How can I classify this is a medication or device? Because some device has the two job. It is device and medication. How can I classify that? It is this product is device, mechanical, or it is a medicine. This is simply by this rule, primary intended purpose is mechanical or physical, this will be device. If the primary intended purpose is pharmacological or immunological, this will be reported as a medical, okay? An EDR report can be should be before delivery and after delivery of device or medication. Before delivery, this is the step of design and manufacturing and quality control and packing. After delivery, this is very important, the performance of the device, whatever the device, ophthalmology device, a surface degradation and the user's errors. Some things related to the staff, to the training. To solve these variance or these errors or failures, as you see here, design for patient safety and reducing user errors by these methods. Reducing user errors and improving education, I mean training. You do more training for doctors and working staff. This will decrease the failure. And here, some registries, and feedback report. This is important for long years, And this is the what happened as withdrawing some products from the market. From the company, from the market, due for the registry of feedback reports, as Dr. Salah said, for long years, they withdraw intraocular lens because of opacity of cloudiness. Some IOLs develop cloudiness. So this is reported, and these products are withdrawn. And we have breast implants, it is a routine in the Western countries for breast implant, and it withdrawal from some company because of what is called, it is cancer. And we have hip implants also withdrawal from the market because of osteolysis and something like that. Yes, thank you.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome to our workshop today about pharmacovigilance. My part about the ADR coding system for the pharmacovigilance. As you see in this flow chart, we have almost about 10 blocks. These are the activities. When you want to report an EDR, what are you going to do? Starting from case receipt to the timely completion of data entering. I will go about every one of these boxes a little bit. This is the same. Complete data entry. For example, in a case receipt, when you receive a case, for example, if you receive a report that there is an ADR or adverse drugs event, we need a mailbox and acknowledgement. When you receive from somebody, for example, a patient, a doctor, telling you that you as a processor here in the pharmacovigilance center, for example, there should be a mailbox, verified mailbox, and you have to acknowledge for this one the reporter that thank you, we received your report about such and such. This will help you that this reporter will be encouraged to send for you more reports. Again, he will not keep sending the same case more again. Once you acknowledge that you received his report. Data verification, how we make that, how we know this data actually is real data. We do, for example, validity assessment for the data, and another activity here we do triage. Triage means that you have to classify your reports. Triaging, classifying your reports. Which reports will given high priority? For example, we give priority to causality and expectedness reports. This will be given high priority. For example, duplicate search. Once you receive a report, you have to look for a duplication. For example, if your search yield a positive, this case was reported before, or the same event had been reported before, then you do follow-up, for example. If this case, your search yield a negative search, then you create a new case. This is a new event or a new drug reaction. And you should have booking and registration. You register this report, this case, as per requirement, and you complete your data entry. The reporting, you should follow the coding system of the adverse events in the medical dictionary for regulatory activities. Medical dictionary for regulatory activities, or MEDRA, this part, medical dictionary. This medical dictionary, it's a coding system, for example. It's a coding system. Just like what we know, the international classification system for diseases. For every disease, there is a special classification. For every event or reaction, there is a coding system. This will make communication easy. Wallahi, when I send this is, for example, ADR number 100 or 200, everybody in the field will know this. What does this mean? Causality assessment, we have to do two things: pharmacology or chronology of the events. The chronology here means the time sequence, whether these adverse events happens after taking the drugs or they were there before taking the drugs. This is a chronology. And also you have to look for symptoms and signs and laboratory tests and pathological findings. This is for your assessment. When the processor, check here, the reported ADR is listed and the expected reference safety in the expected difference safety information. After that, expected seriousness. What are we going to expect as a serious outcomes? For example, disability, death, serious reaction, or something like that. Yeah? Before self-quality check. This is the final slide. Self-quality check. The self-quality check, we have four activities in it. Queries for missing information, the one who reported for you, the adverse drug reaction, or the events. If you have any missing information regarding, for example, the patient name or patient affiliations or something like that, or the drugs type, or what kind of events, you have to ask again. Also, queries are sent to the reporter. Cause of death and autopsy details, if there is. For example, if there is if this patient died due to this adverse reaction, you have to look for autopsy details or reports, and special interest important medical events. Any question?
In this part of this workshop or session, you have an adverse drug event. You report it according to the provisions of the law and of your profession, and the report has been processed the way Dr. Sami has demonstrated to you. So what will happen? The question is, because one of the causes of underreporting is that practitioners have uncertainty that their reports will change anything. We want to show people that your report will lead to be coded and will lead to actions, especially if these reports are causality or serious events. We have the so-called marketing authorization holder. This is the company or the manufacturer of the drug. He is required, if the event is mild and there is no causality or death or permanent disability, he may be required to, by the provisions of his marketing authorization, which he signed, he is obliged to issue the so-called periodic safety update reports to all concerned parties. They call them stakeholders. Or to monitor the outcome of risk minimization measures. Or to assess updates to the risk management system, his risk management system. Or to conduct safety profile studies to his drug, and to conduct analysis and prioritization of safety update or safety update signals. All these are required to be conducted by the marketing authorization holder of the drug. Worldwide regulatory bodies, actions that may be taken can include the following. The very extreme decisions that can be taken are the withdrawal or revocation or suspension of the marketing authorization. The drug can be withdrawn or suspended or revocated. Restriction of the distribution of the drug in certain areas or to certain populations. Or clinical trial suspension if the drug is at the stage of clinical trials. And dosage modification if the event was due to a mistaken dosage. Change in the target population if the event have happened in a specific population of patients. Change of the indication of the drug if the event was strictly related to a specific clinical indication, or change of the formula of the drug, formulation changes if the event was strictly related to a specific formula of the drug, or urgent safety restrictions, or these are the most mild or mild action taken by the regulatory bodies. The so-called Dear Doctor letter. Safety alert letters to practitioners and hospitals. It is called Dear Doctor letter. If a female patient presented to you, you should do so and so and so and so. If a child, a pediatric child in the age group of from 2 to 5 years of age, so and so and so. These are the actions taken by the regulatory bodies. Thank you.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I am very glad today to see you again in this interesting workshop. My part was the practical part. Now you almost master all the theoretical background that allow us to do a practical session how we can report adverse drug reaction. Here we should know there is 2 available forms for reporting adverse drug reaction or used in pharmacovigilance area. This is the oldest one. What should we call it? It will be filled manual yellow card. This is yellow card. Sorry for it will be very sharp yellow in its color, and it is known by everyone. It is almost in the UK, and it filled by the practitioner manually by their hands. It has two types. Next, this is first one. Here we see the wait a moment. This is the patient details, suspected drugs or vaccines. Then here, what the reaction will be reported. Next. Use the arrows. This is another one. Also, if there is another medications, more than one, we can use this form. Now, this is an old version that filled by hand. This is the history. Nowadays, on the spot, in the UK, although we have this very interesting, the government, the National Health, the National Ministry of Health do a very good job. But unfortunately, our pilot survey feel that a lot of Saudian practitioners and others that work within the KSA area, they didn't know this site, unfortunately. It's called Tayaghuz Saudi Vigilance. It is available, and you can access this site by this ada.saudifda.sfda.gov.sa. If you write this, or if you in Google you typed Tayaghuz, you will go directly to this URL. Now, here we can see how we can report adverse drug reaction online, which is more reliable, fast method, and it will be sharing by others and reach the coding and reach the decision maker at very fast way. Here we can see the name of the patient, I think Salah here, you should, this, yes, in your hand booklets, this, we almost do a very dangerous job. We enter, me and Dr. Salah, to this site, and we try to register a fake adverse drug reaction, but we finish and we make a snapshot for your this work. Now you can see here, Salah.
Yes.
Now Dr. Salah, we will show you your hand, and you can follow me by this way. Be careful.
This is the side of the post.
The same thing.
This is a snapshot of our log into the system of the post snapshot. You can revise the details, the required details, to move to next page.
Next page, Dr. Haitham.
In the bottom of at the right hand, there is next, which is an active port. When you touch it, will move you to that next page.
Wait a little bit here, Dr. Haitham.
This is attached. Next page.
Yes. Here it we call 5 elements steps. It is very easy, very fast, and very reliable. 5 elements step. You will see. First step, we will go back further. We record the patient details. Then the suspected direct to how to produce or to exhibit adverse drug. Then if there is another drug add or use at the same time, concomitant drugs that use at the same time, and it will aggravate this side effect. Then in 4, we have the event, which already the theoretical part covered by Dr. Sabi, coding until sending to the. Then lastly, we report this, but be careful. Don't report if you are not sure, because it will be, there is an authorization. Go back, Dr. Haitham. First step here, this is, if you see here, adverse drug event reporting. This is the definitions defined at the beginning by Dr. Salah. ADE, and then we have ADR. Now you are become familiar with these 2 terms and how to use it. This is the patient detail, name, date of birth, either in Miladi or Hijri date, and so on. Weight of the patient, because we know that the precise dose determination is done by the body weight, as you know. Everything. Next. Then here, I think Salah, should start, yes?
You can report on this.
For example, report. Go to your experience, or even and report, for example, your name. Write your name here. Don't worry, it is a paperwork. But if it is online, it is very dangerous. Be careful. But now you can practice this. Use this.
Patient details.
First of all, the first element, patient detail. Fill this to be familiar how to report. And this is the core of this workshop. To gain the skills, enable you to report any adverse drug of ophthalmic drugs or ophthalmic devices, as mentioned by Dr. Mahdi. There is evolution of an instrument, but the risk till now it is not assessed. It may be in the future, in the late future, it will appear the risk and so on. And now you act as a bodyguard. You act as a community bodyguard regarding the risk which was unexpected or unknown, and it is maybe cancer, mutagenicity, and so on. Now you finish this. Online you will find next. Move to the next paper. The same thing. Have some next. You see here the color. The color move from the first step to the second step, and it will be shadow. Now, for example, we try something. We are not ophthalmologists. For example, timolol plus doxazolamide, and you see, generally in our practitioners, our practice, we don't use the trade name for many reasons, you know. But here it is very important to mention the trade name, and even the manufacturer company, because you are reporting a specific issue. So even the dose, percentage, and the route of administration that this drug given to the patient, and the frequency of the dose regimen, 3 times per day, if you, for example, BID. And here on the online, you just click here, and a menu will be start for you, and you can select, for example, use for glaucoma. And this is the duration of action. We know that dose regimen equals amount, time interval, and then the duration for 5 days, 10 days. This you will be reported here. And then, if you press here, you have a lot of action to do. For example, you find the adverse drug that you are already observed is mild or little bit not dangerous. So what is your action? And we see, you can, for example, just reduce the dose, optimize the dose. If you take 10%, you can reduce it to 5% and see. But if there is a worsening in the condition, then it will be go to the further. Here you see there is a lot of things. For example, we take this. This is for your main drugs you want to report online. But for example, if you have more than drug, you have 2, then you press here. Add suspected drugs. For example, you want to report more than 1 drug. You can ask, because this is an interactive session. عم السؤال.
بيسأل بيقول action taken, this action taken. Was it taken by the patient? No, this report is for practitioners. Here for practitioners in their post. And it will give you a select of the actions, of the possible actions that you may have taken. If you have withdrawn the drug, or if you have if you have hospitalized the patient.
Moreover, this is if you have only 1 drug. But if you have more than 1 or 2, you can just press this, and a new form will appear for you, and you can fill it again. And even if there is aggravating factor, for example, synergistic effect, additive effect, potentiating effect, all of this can be reported. Next, Dr. Haitham. Now we move to the concomitant drugs. Drugs that use at the same time with these drugs which expected or already cause side effect, we are interested to be reported. Then either it is drug, vaccine, herbal products, all types that even if it is a diagnostic tool or others, it can be a device. This side effect due to the device, then you can report this. Next, try to fill this. At the end, Dr. Salah will wrap all this session. Try to write something. For example, you are ophthalmologist, and one of these huge devices mentioned by Dr. Mahdi, where you observe when it is used in a certain direction, it will produce a very fatal or serious side effect after 1 day or 2 days. Others, then you can write. ماشي معانا ولا نمتوا؟ طيب.
This is a continuation?
Yes, this is a continuation of the events. Here we have structured questions. You should answer it precisely, and it will lead to a certain decision in the future by the decision makers. For example, it is not clear here, but I think it may be clear for you. You can choose yes or no or doesn't apply. It must be structured because they need a specific answer for this in order to take an action. And there is an optional, or even we have more than events that you can report. Lastly, Dr. Haitham, the last 5, this is the same, this is continuation. This is continuation. The last step was the ending of the reporter. Here, they need your details, your personal detail. Be careful. That is why take it seriously. It is not a joke. Because they need your personal details to take this matter seriously. Here, for example, reporter name, Dr. Mahdi Bashir. Reporter profession, select ophthalmologist. Address, street, PO box, postal code. The country, from inside the KSA or out. The city, Al-Baha. Phone, everything. And they make verification for your personal detail before they take your report, and they will go furtherly. You see, this is written in red. This is warning, alert. Be carefully not to give false information and so on. Then we take it and next. This is in a very brief, informative way how we can report adverse drug reaction online through Tayaghuz. Saudi FDA, they provide this interesting site. And I think this is, if you compare this site or activities with the paper mentioned by Dr. Salah that reflect the status in the Arab countries, I think this is a huge progress. Unfortunately, a lot of practitioners, physicians, and so on, they didn't know anything about this, and that is why we want to highlight this and to spark a candle in this very dark way. And thank you for listening, and Dr. Salah, inshallah, will continue.
Thank you very much, Dr. Ayman, for this very informing presentation. Now I will wrap up this session or this workshop. Drugs are a cause of disability and casualty because of the wide consumption and distribution of drugs. We said that the annual consumption or market of drugs is more than $350 billion per year worldwide. The Americans say that drug casualty or drug fatality is the fourth leading cause of death in America. The fourth leading cause of death in America before car accidents. And drugs and devices need to be under focus for vigilance activity, which is our duty, because drugs are not or do not undergo enough research before marketing, particularly in special patient populations and special ethnicities. So the safety profile of a drug is not complete until 10 or 15 years post-marketing by the so-called post-marketing surveillance, post-marketing or pharmacovigilance activities. In the ophthalmology practice, this is of particular importance because the eye can diagnose different and various adverse drug reactions, and because ophthalmologists also use drugs and devices, very advanced devices, nanotechnology, miniaturization, whatsoever computer software-based devices, and so on and so on and so on. It is our responsibility to report by the provisions of the law. We should report adverse event, even if we are uncertain. And we should be vigilant, and we should know that a single report will make a difference. Stratified reports from Kingdom of Saudi Arabia, from Brazil, from Argentina, from America, from Japan, from China. These signals, when they reach the International Drug Monitoring Center in Uppsala, they will stratify on each other, and a drug with multiple signals will be prioritized for research. And one signal may make a difference in the so-called safety profile of a drug. This is done by gaining the skill of reporting. Each and every one of us should go into the system of the ECOS and have a look at how he can report an adverse drug reaction. If there is any questions, or this is what we have to give. Yes. Yes. The system, the so-called pharmacovigilance center here in Saudi, it will code your report. The report will be processed the way Dr. Sami said. Case receipt, validation and verification, and case entry. And your signal, because there is international collaboration, your signal will be received in Uppsala, Sweden. Similar signals will stratify on each other. This drug will be investigated. If a certain threshold is reached, this drug will be investigated. Locally, the marketing authorization holder will be also informed by your report. And one of the steps we mentioned a marketing authorization holder will take will be conducted. Either as a report will be issued, or as a safety profile report will be issued, or a dear doctor letter will be issued, or a study will be conducted. Yes.